right, so to talk about high frequency ventilation, it shows the picture of the two, I was going to say commonly used high frequency ventilators. Again, the oscillator tends to be used a lot less nowadays, but the jet ventilator seems to be used a lot more. So we'll start off with discussing the oscillator, and then afterward talk about the jet ventilator. When we're talking about high frequency ventilation, we're talking about ventilation at rates of greater than 150 times a minute, all the way up to 900 breaths per minute. So to get air in and out that fast, obviously it has to be really small volumes. We'd say that for tidal volume to be effective, it's got to be greater than our anatomic dead space, because a typical adult, there's 150 mLs of air just sitting in our conducting airways that don't even partake in gas exchange. And then 150 mLs are actually in the alveoli partaking in gas exchange. So if you deliver a tidal volume smaller than that, you're just moving your anatomic dead space in and out. Well, it so happens that's not what occurs, so there's some mechanisms suggested for why high frequency ventilation does such a good job at getting rid of CO2. And they're fancy mechanisms of gas exchange. Pretty much you've got diffusion of gases occurring at the alveolar level, and then as exhaled air is leaving, it leaves on the outsides of the trachea, and the fresh supply of oxygen comes in down the center of the trachea. So at the same time of inspiration, you also have exhalation. All right, so the two types of high frequency ventilators are the oscillator, high frequency oscillatory ventilation. And when you see the ventilator, you'll see that it has like it looks like the speaker. It's black, it's round, and then the speaker just vibrates in and out. And when it comes out, it pushes air into the circuit, and when it pulls back, it pulls the air back out of the circuit. And the same thing is happening in the lungs. It's pushing air in the lungs, and then it pulls the air back out again. So that's one of the big terms used. It says exhalation is active. And then with high frequency jet ventilation, it delivers very short, high pressure jets of air, and exhalation is passive. There's nothing pulling the air back out. So you've got the jet vent just delivering jets of air, and exhalation occurs at the same time as inspiration. Patients that are typically recommended to be placed on high frequency ventilation include an air leak. So if you have a pneumothorax, that means you've got a hole in your lungs. Some alveoli popped, and now there's a communication between the inside of the lungs and the pleural space. And when you put air into the lungs, it just leaks out into the pleural space. So chest tube is needed. So how can you ventilate with positive pressure and expect that area of the lung to heal? And it's very hard for that area of the lung to heal with positive pressure. Positive pressure just keeps blowing it open, and it never repairs itself. But if you place the patient on high frequency ventilation, you've got very low pressure in the alveoli, and that tissue is able to heal. So signs of air leak also include pulmonary interstitial emphysema, where there's ruptured alveoli and there's lots of air getting into the interstitial spaces of the lung. Or if you're on conventional ventilation and you can't ventilate your patient, your blood gases are terrible, you can't even maintain a 7.25 pH, your CO2s are 100, the patient's going to die unless you do something. What can you do? The answer would be high frequency ventilation. And then there's a formula, it's called the oxygen index formula, where you can find out what the oxygen index is. And it's related to the amount of oxygen the patient's on, the mean airway pressure, and the PaO2 that's resulting from that. If it's greater than 19 for 6 hours, that's considered an indication for high-frequency ventilation. So greater than 19 means that you've got severe respiratory failure. What would be a normal oxygen index? Like if you're breathing room air and your FiO2 is 21%, you're placed on a ventilator and your mean airway pressures are 10. And your oxygen level is normal, it's 100. What would your oxygenation index be? Do you have a calculator at your desk?
It'd be 2.1.
2.1 is normal? So 0.21 times 10 gave you...
Oh, times 10. I did times 100. Never mind. So 10 times...
Well, you'll do 100 eventually. Let's see. FiO2, 0.21. Mean airway pressure, 10 centimeters of water.
I did that.
Divide by a PaO2 of 100. So 0.2 times... And then multiply by 100
Yeah,
to
so
put
I
it
was right.
into...
2.1.
Comes out to 2.1?
Mm-hmm.
All right, so a normal oxygen index is about 2.1. So as oxygenation worsens, that number goes up.
So the higher the number, the worse
Yes.
oxygenation is.
Yes.
Okay.
The term open lung ventilation is, when you say open, when you hear open lung, you think opening up the lungs, but it's really not. It's opening up the alveoli. So when alveoli are collapsed, you're not going to get good oxygenation. But if you can keep a positive pressure in the alveoli, you keep the alveoli open and you can get better gas exchange. When we place a patient on the ventilator, the positive pressure causes some problems. It causes alveoli that have normal compliance to get more of the tidal volume, and alveoli that are stiff will get less of the tidal volume. So even if our airway pressures are normal, we're getting volume-induced lung injury by overstretching the good alveoli.
And that's
Volutrauma is the word that it's called,
Oh, okay.
where you overstretch the good alveoli. Some alveoli will open during inspiration and then collapse during exhalation, and that causes tears in the alveolar capillary membrane, and now you've got fluid that leaks out. So here it says relaxation changes in transmural pressure causes breaks in capillary endo and epithelium. So even the capillaries around the alveoli can rupture from these changes in the alveoli opening and closing.
That starts to scar, essentially? Will that lead to scarring?
Yes, it can. So when you have when you have a rupture in the membrane, fluid will leak in and it washes out the surfactant that's there and causes the surfactant to not be effective, and then the alveoli collapse. This is an electron microscope picture, and you can see rupture in, you see red blood cells coming through the breaks in the alveolar membrane. And here's a capillary with a break, and you see the red blood cell coming out of the capillary. So how does high-frequency oscillatory ventilation prevent ventilator-induced lung injury? And it gives you the answer. It says, maintaining a constant mean airway pressure may prevent the incidence of overinflation and deflation, which produces lung injury. So it's lung protection strategy if you inflate the lungs and just keep them inflated without the alveoli having to collapse on exhalation each breath. So keeping a mean airway pressure is one way. With conventional ventilation, we use PEEP to do the same thing. All right, so this imposes ventilation with high frequency versus ventilation with conventional ventilation. So this black line that goes way up is showing a typical breath that we give with a mechanical ventilator. During inspiration, there's higher pressure, and then exhalation, it goes back down to PEEP. With high frequency ventilation, you inflate the lungs, you keep them inflated, and it's called the mean airway pressure. And then the oscillations occur above that mean and below the mean. So I guess it's above and below, like positive, negative, but never negative down to below PEEP or below 0. You've always got a positive pressure kept in the lungs. This is just another picture showing, I'm assuming pig lungs, where if you inflate the lungs and you keep them inflated, then they won't collapse on exhalation. So here, the lung was inflated, but there's no PEEP, so it deflates. And you keep adding PEEP, and then at a certain point, you notice it stays inflated even during exhalation. And then when you allow, what is this, levels of PEEP? All right, so at 20 of PEEP, it's fully inflated. You start backing down on the PEEP, and you notice that the lung stays inflated. So before, on 12 of PEEP, it was still collapsing. But once you get all the alveoli opened and you bring it down to 12, now you still keep the lungs inflated until you go down less than 4 centimeters of water. So that's the point of maintaining PEEP and recruiting the alveoli, is to keep them open so they don't collapse. Oh, it's going to show an arrow where this is happening on the hysteresis curve. All right. All right, so settings with high frequency ventilators. Instead of setting the peak inspiratory pressure, it has a different name, but it's the same thing. It's called the amplitude. The amplitude is measured at the endotube, or actually back where in the circuit is where the amplitude is being measured. However, alveolar pressures are much lower. And the next picture shows that. When you're looking at the circuit and you're measuring pressures, with conventional ventilation, you see pressures go up during inspiration, down during exhalation. The same thing happens in the middle airways, the same thing happens in alveoli. But with high-frequency oscillatory ventilation, as the oscillations go through the conducting airways and get down to the alveoli, they become attenuated, or they diminish as they're going down the airways. So by the time they reach the alveoli, the pressures are very small. So 10% of the amplitude reaches the alveoli in adults. So if you see a pressure reading with adults of 100, at the alveolar level, they're only experiencing 10% of that, or like 10 centimeters of water. So you'll have a pressure of 100 at the endotube or in the circuit, but it's only about 10 centimeters of water down in the alveoli. With neonates, about 1% actually reaches the alveoli, and you'll typically see airway pressures of 25, 28 on the neonates. So 1% of that would be what, 2.8? So the pressure in the alveoli is real, real small. So for that reason, that's why it's a lot more gentle ventilation compared to conventional ventilation. And then when you change the amplitude, you alter the CO2. It looks like it's a 1-for-1. It says to change the CO2 2 to 4 millimeters of mercury, you change your amplitude by 2 centimeters of water. But when you're trying to remember numbers, it's better to just remember the 2 and the 2. So if you have a CO2 of 47 and you want to get it down to 43, you want to drop your CO2 3 points, then how many centimeters of water should you increase your amplitude?
4?
Like 1-for-1 or tit for tat.
Oh, okay.
So if you want to go down 3, then increase your amplitude by 3.
Got it.
Yeah, that would be a better way to remember it. So when you walk up to the oscillator, you don't have an amplitude setting, but you have a power setting. And the power setting tells that diaphragm how hard to push the air. So it's a power setting. But then you'll have a digital readout showing the result or the amplitude, but you're actually setting a power. And then to know if you're ventilating, you don't hear breath sounds when you're listening to the lungs. All you hear is the sound of the piston. So you don't hear air going in and out like you do when you're listening to breath sounds of a patient on conventional ventilation. So how are you supposed to know you're ventilating? Well, you can use that transcutaneous CO2 electrode and keep your CO2s around 40. The other thing you can do is you look at the chest, and if it's wiggling, you're ventilating. Can you believe that? If it's not wiggling, you're not ventilating. So chest wiggle tells you if you have ventilation going on in the lungs. Question?
Yeah, that's the same for the high frequency jet, the wiggle, like they'll wiggle a little bit, correct? Because that's what we've been seeing in the NICU.
Is they're documenting the wiggle with the
And
jet?
it's only measured from their neck to the lower abdomen. If their other extremities wiggle, then the pressure needs to
Be decreased?
Mm-hmm.
Oh, okay.
That's how they're measuring it.
All right. Some of the stuff you're telling me that I don't know, and I didn't realize that. I knew that to judge high frequency oscillation, you look at chest wiggle. So now that they're doing it with jet ventilation, I wasn't aware of that. So, yeah. Go ahead, share whatever you learn. Please share it with me. This stuff changes so frequently. So this is showing what the front of an oscillator looks like and the different measurements. So it's showing you just the power knob. So you crank up the power in order to get your chest wiggle. And then the more power, the higher the amplitude. Document the power setting on the ventilator flow sheet when you're doing your bedside rounds. If the amplitude pressure changes, it may indicate changes in the following. So you would think if you don't touch the power setting, you're getting an amplitude, it should stay the same, right? You have a power setting, you have an amplitude. But there's different things that can occur that are going to cause your amplitude to change, and that's what's listed here. If the patient's lung compliance decreases with that same power setting, you're not going to see your chest wiggle, and your amplitude won't be the same. If you have water in the circuit, it changes, I don't know if it changes the amplitude. All right, I'm gonna let that one go because I know circuit compliance, circuit resistance will affect mean airway pressure, but I wasn't aware that it can affect amplitude. So we're gonna leave that off the list for the moment. Something else that's different about settings for oscillation is you don't set a respiratory rate, but you set Hertz. And for every 1 Hertz, you get 60 breaths.
What?
So a typical starting Hertz for premature neonates with RDS is 15 Hertz. So what is the respiratory rate? If you're setting 15 Hertz and every Hertz gives you 60 breaths.
900.
Yeah, you're giving them 900 breaths per minute. Isn't that crazy?
Unheard of.
And then as you turn down the number of Hertz, you're going to get a bigger tidal volume. Yeah, so when it's going really fast, it gives little volumes, but as you slow it down, it gives bigger volumes. Matter of fact, when you're putting an adult or large kid on the oscillator, the Hertz setting is 6 or a low number. So 15 for the babies, like 5 or 6 for big kids and adults. So it tells you that the CO2 removal improves when you lower Hertz because you're increasing the tidal volume with a longer inspiratory time, and there's a longer time for exhalation. Also, the piston has time to move more distance. So when you slow it down, it can move forward further, it can move back further, and that's going to change the size of the tidal line. So fast and little, slow and big. The frequency, or the Hertz, controls the time allowed for the piston to move. More time allows the piston to move a further distance. Therefore, the lower the frequency setting, the greater the volume displacement, and the higher the frequency setting, the smaller the volume displacement. So this is saying it again, just different words. It's trying to show you when you have a faster Hertz, you have a shorter cycle time, and therefore shorter time for inspiration and exhalation. When you slow it down, you get a bigger volume because you've just got more time for the air to go in and out. Okay, so instead of respiratory rate, you're going to see frequency and Hertz. All right, so if you get a blood gas and the CO2 is high and you want to get rid of some CO2, I told you one thing you could do already. What was that?
Lower the Hertz.
Okay, yeah, and that's the second thing. So I already mentioned the amplitude. You can go up on your amplitude, and that'll get rid of some CO2. And then the other thing would be to lower Hertz.
So go up on amplitude and lower Hertz.
Yeah. Typically, the Hertz is the last thing to change because it goes according to body size. Usually not the first thing you would change if the CO2 is high. All right, so it does affect CO2, but it's not the first change you would make. Amplitude would be the first change you make.
Okay.
So this is just showing how with the preemies you start off with 15 Hertz, but by the time you're greater than 60 pounds, you're down to 6 Hertz. So the frequency or the Hertz may or may not be adjusted from the initial setting. Frequency is not weaned, as is done with conventional mechanical ventilation, where you turn the rate down. Because if you turn the rate down or the frequency down, you're actually increasing ventilatory support with this. So that's a big difference. Like if I ask you to compare conventional ventilation with high frequency oscillation, what is the difference between them? You would say if you turn down the Hertz, you're actually giving a bigger tidal volume and more ventilation. All right, so mean airway pressure is used as the distending pressure. It's similar to PEEP where both of them increase FRC. The difference between them though is with PEEP, you never go below PEEP. PEEP is your baseline, your bottom line. With mean airway pressure, you're ventilating above the mean and below the mean. So the air goes in and comes out, and it's above and below the mean. Mean airway pressure improves oxygenation. Again, when we have the airways stented open, we've got better gas exchange occurring. Adjust the mean airway pressure according to the level of the infant's diaphragm on chest x-ray. So the more the mean airway pressure, the more air trapped in the lungs, and the more you're going to push the diaphragm down. So if you push the diaphragm down to like the 11th rib, and the x-ray report says diaphragm is at the level of the 11th rib, what would you recommend to improve that?
Decrease amplitude?
Decrease the amplitude?
Or the hertz?
The hertz?
The mean
The mean airway
I'm
pressure.
sorry. Yeah,
Yes.
we're on to most.
All right, so how do you get the mean airway pressure? Well, you put this flow going through the circuit, and that flow going through the circuit will also go into the airways, and it's called bias flow. So you'll see a flow meter, and you just crank it up until you get your mean airway pressure. Bias flow also flushes out the exhaled CO2 that's in the circuit and in the airways. And this is saying the same thing, but with some pictures. So you'll have a flow meter on the front of the oscillator, and you turn it up in order to get your mean airway pressure. It says mean airway pressure is created by a continuous bias flow of gas past the resistance or inflation of the balloon on the mean airway pressure control valve. So I'll show you a picture of the circuit. Somewhere there's a picture of the circuit. The I time is put at 33% and basically stays there. So when you're writing down all of the settings for the oscillator, write down your I time, but it'll almost always be 33%. I guess the picture of the circuit's on the other handout. I think this is a little more than you need to know. It just says inspiratory time is forward movement of the piston, so that'll push the air into the lungs. Expiratory time is pulling backwards and pulling the air back out of the lungs. That's pretty much it. IE ratios you're familiar with. It says that if you increase the I time, you can help with CO2 elimination, but that, you don't see that done too much. All right, and then the last slide, comparing conventional ventilation to high-frequency ventilation. All right, in the middle it has, you determine ventilation and you draw blood gas and you look at the CO2 in the blood to determine if you're ventilating properly. With conventional ventilation, we'll change the rate and the tidal volume to achieve that. With oscillatory ventilation, we change the hertz and the amplitude. For oxygenation, with conventional ventilation, we use our PEEP and FiO2 controls. But with high-frequency ventilation, we use the mean airway pressure and FiO2. Okay? Saturated.